Thank you very much. I would also like to express my gratitude to the National Academies and the organizing committee for the opportunity to speak to you today. Obviously, Dr. Fullerton and I really like this graphic. So to again drive home the point that as more companies enter the direct-to-consumer retail market for genomics, the increase in numbers of genotyped consumers will allow for an exponential increase in innovation. But this is only going to happen if the reach expands beyond individuals of European descent. Analysis of rare variations becomes much more powerful when sample sizes increase and become more diverse. So bias in the existing foundation of the data is exacerbating disparities. Underrepresentation of non-European and rural and underserved populations in genomic databases is problematic. Our genome is constantly adapting in response to environmental and biological signals. Thus, limited generalizability of findings from genomic research exists as we are missing substantial genetic variants. Clinical interventions, polygenic risk scores, and guidelines for risk reduction and management of complex chronic disease may be largely inaccurate, resulting in limited evidence for translation of findings into clinical practice, particularly for diverse populations. I would like to provide a bit of background about what we know about rural and underserved populations and engagement with genomic services, interspersed with my own experiences in practicing clinical cancer genetics over the last 15 years. In a community-based participatory study of rural Appalachians in West Virginia, more than 50% of participants report having a high interest in participating in genetics and genomic studies to improve health. Many individuals are concerned about the influence of environment on health, including how exposure to harmful substances may be changing their genome. And this is something that I hear repeatedly in my own practice in Eastern Kentucky, where coal mining remains a major industry. In the study, while half of the participants felt genetic studies were not risky, the other half cited fear of the unknown. This can be a barrier to pursuing genetic testing at all. Participants also noted concerns that knowledge about disease risk would not actually translate into action to prevent disease occurrence. Mistrust or low confidence in healthcare provider knowledge about genetics was also cited as a barrier. Pervasive and persistent health disparities in rural populations contribute to many of the problems related to the use of direct-to-consumer genetic services. Yet, health disparities are the very reason why the focus on improving inclusion of rural and underserved populations is imperative. Several studies have explored factors affecting use of consumer genomic services. I've bolded the factors here that I've seen most commonly in my own practice. But it's important to recognize that this literature is still evolving and developing, and little knowledge exists specific to rural and underserved areas. First, there is an overall lack of awareness of direct-to-consumer testing among rural residents. In a study of the National Health Information Trends Survey, healthcare professionals were cited as the least likely information source for genetics. Awareness of genetic testing can also vary by acculturation, race, and ethnic identity. Lack of awareness of genetic counseling also exists. In a personalized medicine coalition survey of just over 1,000 people, 73% had never heard of genetic counseling. This is critical because individuals who may want assistance with interpreting their direct-to-consumer test results may not know of the resources for genetic counseling or have access to these services, particularly in rural areas. To illustrate this point, you can see the purple star is where I practice in Eastern Kentucky. So Lexington is about 2.5 hours away for the next closest genetic counselor. Louisville's 3 hours away, Knoxville 3.5 hours, Raleigh's close to 4 hours. So, and there are actually, per the NSGC, no reported genetics counselors at all in the state of West Virginia. Cost is one of the most frequently cited barriers affecting use of consumer genetic services. In the Personalized Medicine Coalition survey, 25% noted they would be willing to pay between $50 and $100, but 30% stated unwillingness at all to pay out of pocket. Privacy concerns were also noted. Only 10% said that their provider had ever talked with them about or recommended a genetic test to diagnose them with a disease or guide treatment. In a systematic review of the literature from 2012, a majority of consumers noted that they preferred guidance from a healthcare provider regarding the use of direct-to-consumer tests. But as mentioned earlier, sociodemographic factors cut across many of these areas. Family communication is a major area of emphasis for individuals in rural areas, particularly in areas where I work, where family ties are very, very tight. This can have both a positive and a negative influence on the discussion about genetics and family history. While the number one reason for participating in genetic testing is to learn information for family members, concerns about guilt or fear of passing on genetically linked health conditions can be a major deterrent for testing as well. Individuals in my practice have often not given any thought to these types of discussions that may need to occur in families regarding genetic testing. This particular aspect of my interaction with patients takes about 10 minutes to converse about. Fear of discrimination is cited in the literature, but over time I've seen this factor seems to have decreased for some populations. And again, one of the most important aspects to these factors is that they are dynamic. So many of the barriers can change over time. There are several speculated advantages for direct-to-consumer testing for underserved populations. Supporters certainly cite patient empowerment as the primary reason for DTC testing, and in addition, relative affordability, non-invasive sample collection, and increased accessibility to genetic testing may also be advantages. Certainly, increased patient engagement can lead to overall improvements in genetics literacy. However, there remain several challenges to direct-to-consumer genetic testing for underserved populations. First, there are many questions regarding the accuracy of the genetic test results. Results of DCT testing are not definitive, and when additional testing is needed to confirm a variant or because there is a clinical indication to do so, many patients can't afford the costs associated with this because they lack health insurance or the inability to pay for these costs out of pocket. Important decisions about treatment or disease management may therefore be based on incomplete, inaccurate, or misunderstood information on the part of both the patient and the provider. In addition, direct-to-consumer tests do not necessarily achieve improved access to those who have existing barriers to access for general health care needs. Providing the availability of the test gives little assurance that health outcomes will change for patients. This, of course, may lead to unintended psychosocial consequences. In addition, genetic privacy may be compromised if companies use results in an unauthorized manner. The use of wrap contracts can result in consumers unknowingly consenting to terms and conditions regarding the privacy of their genetic data. Closely tied to this is the concern about whether the risks to one person's data also pose a risk to that person's relatives. Several opportunities exist to expand the reach of all types of genetic testing, including direct-to-consumer, consumer-initiated testing with a healthcare provider, as well as provider-initiated testing. In the next few slides, I'll provide examples of ways in which acceptability and affordability of testing and genomic literacy can be improved. In my own practice at Pikeville Medical Center in Kentucky, I developed the cancer genetics program as a result of noticing a gap in care. I've been there since 2010. I've undertaken many strategies to improve the acceptability of testing over the years. It's also important to note that I am not a genetic counselor, but rather an advanced practice nurse and nurse scientist with a background in genetics. About a year ago, I approached 2 of our nurse navigators to serve as genetics nurse navigators. Their primary role is to help patients complete family and personal health history information during a routine visit with the oncologist or over the phone. The navigators also provide an extensive overview of what will happen at their visit with me, including providing background about me as someone who is not from that area. This is very important to improve trust. Patients are scheduled after they have completed a 3-generation family history questionnaire, and this has improved also the no-show rate for cancer genetic services. In fact, I've seen a 54% increase in patient encounters from now and as compared with this time last year. I've also partnered with the community in two distinct ways. First, I've worked over the last 2 years with the Health Wagon in Southwest Virginia, which is a nurse-led initiative providing high-quality care to the medically underserved, and they have both a clinic and an RV that they drive into the rural areas to provide care. Their patients, 98% are uninsured, and 70% live on an income of less than $20,000 a year. Given the cancer disparities in that area, many patients have a clinical indication for genetic testing. To overcome the cost barrier, I partnered with Invitae Genetic Labs, and patients referred from the Health Wagon are now able to come see me and get their genetic counseling and testing for free. This was possible given that patients already met the criteria for patient assistance, but we removed the barrier involved in the process of applying for patient assistance, given that they already met criteria to be eligible for services with the Health Wagon. In July of 2020, I will spend 3 days in Wise, Virginia with Remote Area Medical, where I will work with Doctor of Nursing practice students to provide screening of those at risk of hereditary cancer based on personal and family history, and then also ensure that they have access to care at the hospital where I see patients. Telemedicine and faith-based opportunities are also avenues for increasing the reach and promoting accessibility to genetic testing. One of the most valuable lessons from working with rural individuals is understanding that you need to meet them where they're at. Communication is key, including the specific language that's used. So for instance, I never talk about genetic mutations, but rather genetic changes. And I level the knowledge that's needed to get the patient to understand what that's appropriate with their level of understanding to begin with. So I always ask at the start of my visit, can you tell me a little bit more about what you know about why you came to see me today? Tell me what your oncologist told you about why it was important to come see me. I spend about 45 minutes with all new patient consults and 30 minutes for results disclosure. Spending time is of critical importance. I review all patient and family history information before I ever walk into the room, so this assures that I'm more efficient at my visit, but also allows me the opportunity to talk with people about their family, which is not only important in Appalachia, but also important if it becomes necessary for other family members to be tested. Overall, it's very important to recognize that genetic test results, including direct-to-consumer tests, can be confusing. There can be conflicting information across companies and providers. In my experience, some providers may order testing and not provide results, or provide misinformation or incomplete information about results to patients. Lack of communication with patients can lead to numerous family implications resulting from genetic testing in the direct-to-consumer space. The implications for patients are inherently the implications for providers. The landscape of genetic and genomic testing is rapidly evolving, and healthcare providers of all types must be informed about genetic and genomic testing and take time to seek these resources for their practices and for their patients. Yet, saying that providers must be better educated and informed doesn't translate to action. Healthcare providers are only minimally effective when they lack adequate knowledge or a good understanding of the needs or perceptions of their patients. Strategies must be undertaken to improve genetics curricula and healthcare provider education programs, but of course, this only addresses the needs of healthcare providers in training, and we must also address the needs of those who are practicing. So for instance, where I work, I've had many encounters with oncologists who don't necessarily understand the differences between germline testing and somatic cell testing. So I'd like to share a case study, it's very short, about a 31-year-old female who lives 2 hours away from my practice, but came with her sister for disclosure of genetic test results. Their mother was diagnosed with breast cancer at 49, and their sister was diagnosed with ovarian cancer at 44. The maternal grandmother was diagnosed with breast cancer at 55. And so the 31-year-old individual had the 23andMe test for the 3 Ashkenazi Jewish variants, and her results revealed that no variants were detected. And so when she came to the clinic, she said, "I feel so blessed that I did not have this breast cancer gene and that I can live my life without this worry." I then disclosed to her sister that she had a BRCA2 mutation. The proband required, of course, a discussion of personal implications of testing for her and more tailored treatment, but also implications of testing for other family members. So the sister who had the DTC test, who was there as a support person, was becoming visibly uncomfortable because she was realizing that perhaps her genetic test results didn't tell her the whole story. So she did agree to site-specific analysis, and I disclosed her results 2 weeks ago. She was also positive for the BRCA2 gene mutation and felt incredibly cheated by her 23andMe test. I also had 20 patients referred by rural family medicine practice after a Facebook ad that they posted for cancer genetic testing done by a lab that wasn't CLIA certified. Results came back, and family physicians didn't know what to do with them, so they called and said that they had 20 patients that they needed to refer to me because they didn't know what those results meant. So whether we can achieve balance is a tremendous and difficult question. In order to do this, there needs to be a balance between patient autonomy, clinical utility and ensuring patient safety, and technological innovation. Consumer genomics disintermediates personal genetic information by removing the healthcare provider, but this approach may threaten the broader implications related to medical management as well as psychosocial consequences of genetic testing. There is a critical opportunity for multiple sectors to come together to ensure proper inclusion of all individuals in genetic and genomic testing, scientific interpretation of genomic data, including risk interpretation and response, drug and other therapeutic developments, and regulation of direct-to-consumer retailers to include adherence to strict standards for clinical testing without overreach and medical risk communication. I'll stop there and look forward to your questions.